So, welcome everybody to the third episode of this Renal Regain Classroom program. And in each session, we usually cover one of the topic, and related to it, everything is usually discussed. As before, it has three parts. In the initial part, we have a case discussion, is a presentation followed by examination style discussion, followed by there will be an OSCE sessions on some other topic, and at the end there will be this discussion regarding the researches on this field. For this first session, there is a case presentation. Today's case will be a renal transplantation, chronic graft dysfunction, and that will be presented by Dr. Pallavi Dubey. He is a third-year resident in Manipal Hospital, Bangalore. And today's examiner, we are very fortunate. My examiner, our examiner, an examiner of very other nephrologist, Professor R.K. Sharma. He is presently working as an chief of this nephrology and transplantations in Vedanta Hospital, Lucknow. But we know him as a professor, director, head of SGPGI for a long time. He was secretary of the Indian Society of Nephrology, Indian Society of Organ Transplantation for a long time. He has innumerable publications, and he has taken probably more than 100 examinations and for the different generation of the students. So without wasting much time, we welcome you, sir. And we'll start the proceeding, and after that there will be OSCE session. Today's discussion mostly on the renal stone diseases, and lastly Dr. Aniruddha will discuss about this BANFF journey, what are the changes on the different BANFF conferences on the transplant rejection diagnosis. So Dr. Pallavi, with the permission of your sir, you can start the presentation.
Yeah, you can start.
Good evening, teachers. I'm presenting a history of sir, am I audible enough?
You are audible.
Yes, sir. I'm presenting the history of a 46-year-old gentleman, non-diabetic, hypertensive since the last 10 years, status post-live related renal transplant in 2012, currently presented to us with graft loss and is being worked up for second renal transplant when I took the history. I would like to date back my history to 2007, when the patient visited a local hospital with complaints of on and off headaches with mild pedal edema on long travels. He also gives a history of frothy urine. The patient was relatively asymptomatic before this. He was found to have a blood pressure of 200 by 100 mmHg, and routine test done at this point revealed a creatinine of 1.4 milligram per DL. And he was told to have kidney disease with some protein leak in the urine. 24-hour urine collection was also done, which he does not recollect, however. He subsequently underwent a renal biopsy for further evaluation and was told to have kidney disease. He was started on 2 antihypertensive medications and was advised a low-salt diet with strict blood pressure control. No special injections or tablets were added post-biopsy. The patient was, however, lost to follow-up after this. He did not get his routine blood test or BP measurements done and was non-compliant to medications. He also reports that he had frequent headaches, for which he took over-the-counter painkillers. In 2012, the patient presented to us with complaints of vomiting, loss of appetite, and breathing difficulty to the emergency department. He was found to have a creatinine of 10 milligram per DL with uremic signs and symptoms and volume overload, and hence was initiated on hemodialysis via right IgHT catheter and was advised to continue maintenance hemodialysis 2 to 3 times a week. The patient had 2 to 3 episodes of pulmonary edema after his initiation of dialysis, and his dialysis frequency was increased to 3 times a week. Permanent access was not created as the patient was being worked up for a renal transplant. He, however, did not have any admissions for any catheter-related infections or other dialysis complications in between. In July 2012, the patient underwent live-related renal transplant with mother as the donor. It was an APO-compatible renal transplant. He does not remember any special or costly injections being given during or after the transplant, before or during the transplant period. The patient was told to have slow graft function, however, post-transplant, and a renal biopsy done on post-op day 10 for evaluation. There was no decrease in urine output or worsening hypertension as he remembers during this period. Post-biopsy, the patient was told to have features of rejection and was given some special injections. The patient was discharged on post-op day 13 with a creatinine of 1.6 milligram per DL on standard triple immunosuppression in the form of tacrolimus 3 milligrams per day, mycophenolate 1 gram per day, and prednisolone 30 milligram per day. Tacrolimus level was told to be within therapeutic range at that point of time. In December 2012, 6 months post-transplant, the patient was admitted with acute febrile illness and was found to have a urinary tract infection with culture positivity. Graft function was stable at this point of time with creat of 1.5 milligram per DL. The patient was in regular follow-ups with us and he had stable graft functions from 2012 to 2019 with the creatinine being around 1.3 to 1.4 milligram per DL. In 2019, the patient started noticing pedal edema and frothy urine with worsening hypertension control and increase in number of BP medications was needed. His creatinine had jumped from 1.3 to 1.9 milligram per DL in 7 days duration. There was no decrease in urine output. The patient underwent renal allograft biopsy and was given 2 doses of solimidrol 500 mg, methylprednisolone 500 mg. He achieved a creatinine of 1.6 milligram per DL post the injections. However, he had gradual worsening of creatinine from 1.6 to 2 to 2.5 in the next 2 to 3 years till 2023. In March 2024, the patient was admitted with multiple loose stools and dehydration with a rise in creatinine from 3 milligram per DL to 7 milligram per DL. The stool culture was positive for entamoeba histolytica and patient was treated with IV antibiotics, hydration and discharged with a creatinine of 4 milligram per DL. Over the next 6 months, the patient had worsening renal functions and presented in November 2024 with a creatinine of 11 with pedal edema, breathing difficulty, and reduced urine output. The patient had uremic signs and symptoms on presentation and was initiated on hemodialysis via right IJ catheter and is currently undergoing hemodialysis 3 times a week. The patient is being worked up for second renal transplant with wife as the donor. The patient is highly sensitized and is planned for desensitization protocol. So the history part is this much, sir.
So, based on the history,
yes, sir.
You want to, sum up and come to some diagnosis, clinical diagnosis?
Yes, sir. So, summarizing the case, he is a young male, 46-year-old, non-diabetic hypertensive, status post live-related renal transplant in 2012. The patient has undergone 2 allograft biopsies. One was done on post-op day 10, which was treated with probably solimidrol, and repeat biopsy done in 2019, which was again treated with solimidrol. His baseline creatinine achieved was around 1.3 to 1.4 milligram per DL. However, from 2019, he had repeated episodes of, he had worsening creatinine, increasing from 1.6 to 2 to 2.5 and gradually increasing to 7 last year. He currently presented with graft loss and with a creatinine of 11 milligram per DL. With this background history, I would like to, syndromic diagnosis would be allograft dysfunction with graft loss. My DDs would be, first DD would be chronic rejection, ABMR more likely than ACR, CNI toxicity, and third DD would be BKV nephropathy. Initiated on hemodialysis currently with right IJ catheter. His background history is hypertension, non-diabetic, CKD since 2012, NKDs are CG and likely. In that, I would like to keep mostly IG and nephropathy as one of my DDs, sir.
So, do you like to know the original kidney biopsy report?
Yes, sir.
Have the biopsy report or no biopsy?
Biopsy was done actually at an outside center, so we did not have the report with us, sir.
Okay, so you have three diagnoses which you have made. First one is the chronic. Can you repeat the 3 differential diagnoses?
The first would be rejection, chronic antibody-mediated rejection, more likely than chronic cellular rejection. Chronic antibody-mediated rejection, sir, CBMR.
Okay.
Then second would be CNI toxicity, and third would be BKV nephropathy, sir.
Third would be BKV
yes, sir.
nephropathy.
Yes, sir.
So, I mean, is there any other possibility?
So one other possibility would be recurrence of the native kidney disease, but his after 2019, his creatinine has very slowly progressed from 2019 to 2024. In between protein quantification, we are not sure, but his CKD original disease, I would think of IgA nephropathy, which does have a 30 to 40% chance of recurrence. So recurrence of native kidney disease could be a possibility, sir.
So based on the whatever information we have, you have kept number one, the chronic antibody, then the CNI toxicity, and the third is BKV.
Yes, sir.
So how do you justify one by one?
Yes, sir.
And
So,
then your reasons for trying to, I mean, put CBM antibody-mediated rejection as number one, chronic, then CNI and BKV.
yes, sir. So, first, with the background history that he had an episode of rejection on post-op day 10 with a repeat episode of rejection in 2019, that would increase his chances of allograft nephropathy, chronic allograft nephropathy, secondary to rejection itself. So, CABMR would be high in possibility. CNI toxicity, he's been on tacrolimus for almost from 2012 to 2024. Tacrolimus levels have been in therapeutic ranges all through his post-transplant period. Chronic prolonged exposure to CNIs with gradual increase in creatinine would be expected in CNI toxicity, sir. Chronic CNI toxicity with one episode for acute dehydration that might have led to further worsening of the renal functions. BKV nephropathy, because he has received net immunosuppression over the years, has been quite high because of 2 repeated episodes of rejection. So his cumulative immunosuppression is quite high, sir. So BKV nephropathy is slowly progressing almost 7 to 8 years after transplant. That would still, I would like to consider, sir. And
Okay.
last,
Yeah, last you said is the recurrence.
recurrence, sir.
If you're talking about chronic ABMR,
Yes, sir.
so whether you like to, you mean chronic active ABMR?
So currently he has progressed to almost 10 stage renal disease. So it would have transformed likely to chronic inactive ABMR, sir. But after the first episode of rejection, when his creatinine was gradually increasing from 1.6 to 3, when we have not biopsied him further, at that point, I think he would have chronic active ABMR, sir, which left untreated has progressed to chronic inactive ABMR as of now, sir.
So when the second biopsy was done,
yes, sir,
he had probably acute this rejection, which was
yes,
treated like a, was it a T cell mediated rejection or an antibody mediated rejection?
he was based on the treatment.
Based on what information you have? Because
Yes,
they have not given you the kidney biopsy report.
Yes, based on the treatment given, it looks more of acute cellular mediated rejection, sir. He has been treated only with 2 doses of solimedrol. He has not received, he has not undergone any plasmapheresis or any rituximab further for evaluation of ABMR. So based on the information we have, ACR would be more likely at that point, sir, 2019.
Okay. And within that second rejection, within
Yes.
how much time he has reached end stage renal disease?
So, the second episode of rejection was in 2019, sir, and he's reached end stage renal disease in 2023 end to 2024, sir. He was running at a creatinine of 3.454 at the end of last year, sir. Now,
so maybe 5 years
yes,
down
sir.
the line. So you are seeing this patient at this point of time.
Yes, sir. Yes, sir. When he came with a creatinine of 11, sir.
So why are you still considering chronic antibody-mediated rejection? Because when you think chronic antibody-mediated rejection, that means probably active, or you think totally burnt out.
So currently, with a creatinine of 11 with pedal edema, reduced urine output, it would more likely be burnt out kidney, sir.
So your diagnosis should be,
yes, sir.
see, The issue is that what would be our first diagnosis now at this point of time?
Yes, sir.
Because if you consider chronic antibody-mediated rejection,
yes, sir.
then you are thinking about possibly the biopsy will also show something. I will ask what it could show.
Yes, sir.
And then there may be some treatment available.
Yes, sir.
Or treatment would be done. Okay. That is not being done
Yes,
or
sir. No.
considered. So I'm saying just because there were 2 rejections, which was documented with the biopsy reports and also the treatment,
Yes, sir.
there is there any other diagnosis which you would consider in this patient, which you have not listed? Because you have listed 3, which is the BKV. BKV is also something which needs some treatment.
Yes, sir.
And the other one you said CNI toxicity.
Yes, sir.
So is there anything else which comes to your mind, which is actually at present the clinician whoever is looking after has come to that conclusion, rightly or wrongly? I'm not saying.
Yes, sir.
Biopsy will be still will the question will come whether it should be biopsied or not.
Yes, sir.
So what clinically what would you term it? Something which is not chronic active.
So chronic allograft nephropathy.
So what is the term? Because we'll have Anirudh talking about the BANFF classification. What is the term which is mentioned in the BANFF classification? And why that term, which is also controversial term? And which is more a pathological term.
Yes, sir.
What would you say if it burnt out?
So the
dysfunction or chronic allograft dysfunction. Previously, sometimes it used to be called CAD, chronic allograft dysfunction.
So now CAN also has been actually changed.
Sorry?
The term CAN also actually has been
Chronic
recommended.
allograft nephropathy, yeah, that is another term. But there are so many terms. Some of them are confusing. And then what would the biopsy show? That is mainly a histopathological term, but it also used by clinicians. You have heard of IFTA?
Yeah, so IFTA would be, IFTA would be at least more.
Chronic allograft nephropathy with mainly IFTA.
Yes, sir. Yes, sir.
As do you feel that is more likely, or do you think it is chronic active AVMR?
Currently, when he's almost at end-stage renal disease, it would be chronic allograft nephropathy with moderate to severe IFTA, sir.
Yeah, but so I think you should keep that as the first possibility. And also, definitely you will still look at the other entities which you have listed. So why do you think it is CNI toxicity as a possibility?
So CNI toxicity, his cumulative, he's been on tacrolimus since post-transplant 2012. And after 2 episodes of acute rejection, probably his net immunosuppression would have been increased. Tacrolimus levels have been adequate. So his expectedly, I'm not aware, so that he was not aware if TAC was increased or not, but expectedly after the second rejection, we would have increased the tacrolimus levels, sir. So prolonged exposure to tacrolimus would definitely be, there would be a chance of CNI nephrotoxicity, sir.
Okay.
Or 10 years of CNIs.
And the BKV, what is suggested that it's a BKV?
So BKV can have, he did not have any current clinical signs or symptoms. BKV can always be a silent manifestation. And
so what signs and symptoms you would expect?
So in BKV specifically, one would be So urethral stricture or stenosis is one of the things clinically that we can see. Other
Yeah.
than that, most BKVs are clinically silent, sir. It
Yeah.
is more often that we need to more often diagnosis made by screening actually, and not by clinical presentation after ruling out the other DDs.
Yeah. So even ureteric stenosis and all clinically may not be very
Yes, sir.
symptomatic,
Yes, sir.
but that's a very uncommon manifestation.
Yes, sir.
So you have to consider these possibilities.
Yes, sir.
So what would be if this patient comes to you at this point of time?
Yes,
You can finish anything, I don't know, the history. You have talked about family history and
that is pending actually.
okay, you can finish the whole thing, then we can go on.
Yes. So family history, he's a single child with mother being mother and father. Mother is currently not alive. Mother had hypertension. Father did not have any comorbidities. No other significant family history. No family history of kidney disease or any near relatives being on kidney disease or on dialysis. Personal history, he's a non-vegetarian. He's a non-smoker and non-alcoholic. No other significant addictions in the routine life, sir. Examination wise, when I examined him at this point, his pulse was 80 per minute, blood pressure was 180 by 90 mmHg in radial artery, bilateral. There was no radiofemoral delay or radial delay. Respiratory system, he had bilateral fine crepitations. His saturation was around 92 to 93% on room air. His JVP was elevated, sir, and he had bilateral pitting pedal edema. His respiratory rate was around 20 to 22 per minute. There were no other significant positive findings in the examination, sir. He had a complaint of reduced urine output, but he had not quantified around 300 to 400 ml in the last 24 hours, sir.
Okay. So,
And sir, he had tremors also.
he had tremors.
Tremors, yes, sir.
So is he, what immunosuppression he is on at present?
Currently, after his creatinine has been worsening, tacrolimus has been reduced to a minimal dose, sir. Almost only 0.5 mg currently, sir.
So 0.5 mg every day.
0.5 mg BD, sir, BD. So 1 mg per day, sir.
Okay. And anything else or?
So he was on this tacrolimus 0.5 mg BD, mycophenolate 180 mg BD, and Visolon 5 mg OD, sir, currently.
Okay.
And
So
and-
he's still on triple immunosuppression, but
yes,
much doses
yes.
are very much
Planned
reduced.
for second renal transplant in December itself. So we have continued the tacrolimus and the mycophenolate, sir.
Okay. So when this patient comes to you,
Yes, sir.
investigations are not. You have seen this patient, or only the history has been given to you?
So he's being currently worked up for renal transplant under us, sir.
So he is with you only. Okay.
Yes, sir.
So what would you do in this patient? This patient comes to you at this point of time.
Yes, sir. So at this point of time, his creatinine is almost 11. EGFR would be less than 10% because of creatinine slowly increasing over the last 1.5 years. I would expect severe IFTA in the kidney biopsy. So I would not be too aggressive with performing a kidney biopsy. In view of uremic signs and symptoms, I would manage him with hemodialysis. If he has plans for, if he does not have plans for a further renal transplant, then I would like to create a permanent access and continue maintenance hemodialysis and taper the immunosuppression gradually with first withdrawing mycophenolate and keeping tacrolimus to a minimal level, withdrawing tacrolimus and keeping him on minimal dose of Isolon, sir, which he's on 5 mg for graft tolerance. If he's being planned for second renal transplant, which he is, sir, with wife as the donor, I would like to, because he's a sensitized recipient with a history of first renal transplant, I would like to get his immunological workup done, his cross-match, flow cross-match, and single antigen bead assay, sir, and to look for any specific donor-specific antibodies against the current donor. If he has his donor-specific antibodies are high, then I would like to plan desensitization for him before the transplant, sir.
But what you have told us that patient is sensitized. That is
Yes,
number one.
yes, sir.
Okay. So my question is that how do you evaluate this patient? And suppose this patient would have come to you when the creatinine was 4 or 5.
Yes, sir.
How you would have evaluated this patient?
So if he
Because
had,
you have to now, initially you have not considered the diagnosis of IFTA
so
in your list.
now it is IFTA would be severe only, sir, at this point
That's
of
what I'm
time.
saying.
Yes,
So
sir.
suppose if he had come to you when 4 creatinine, serum
Yes, sir.
creatinine 4,
Yes, sir.
and everything same,
Yes, sir.
and
So,
he's bringing his wife as a donor,
yes, sir.
and he wants to go for a preemptive transplant.
Yes, sir.
So how do you evaluate this patient?
Sir, with a creatinine of 4 or 5 also, his EGFR would actually be quite low, sir, almost less than 10 to 15%. At that point also, his expected IFTA in the biopsy would be quite high. He would be in moderate to severe IFTA, unless the jump in creatinine has been acute, which in this case, it has been a gradual rise in creatinine over from 2019 to 24. So less likely that any amount of activity would be found in kidney biopsy, or we would be able to offer any treatment based on the biopsy. So again, even if creat was 4 to 5, I would differ from a kidney biopsy. I would manage him conservatively till uremic signs and symptoms predominate, or he has any pulmonary edema for initiation of hemodialysis, and work him up for preemptive renal transplant, sir.
So in that case, you are making 3 or 4 differential diagnoses, like especially BKV
Yes,
and
sir.
also the recurrence of the disease.
Yes, sir.
So you don't want to rule them out, or it doesn't matter?
So if the increase in creatinine has been quite gradual, then if the increase in creatinine has been very gradual, then it is less likely that with such a high creatinine and less EGFR, we gain anything by that. Recurrence, however, we can look for urine analysis if there is new onset proteinuria, which earlier he did not have proteinuria. So new onset proteinuria would be one indication to look for recurrence or worsening hypertension, but that could also be in favor of chronic ABMR, so CABMR, new onset proteinuria or worsening hypertension.
Yeah, the basic point is that we don't know the initial biopsy, that number one. Suppose you have said, I'm only talking from clinical point of view, you only said that IgA was the possibility.
It was one possibility.
So if you want to consider recurrence, then biopsy will give you information. I mean, it is not that treatment would reverse it or not.
Yes, sir. Yes, sir.
Secondly, if you think no BKV, again biopsy will be giving a lot of information, because what is the other test which can guide you for BK virus infection?
We could do urine for decoy cells, and that would be a screening test. Blood BKV copies could be looked at. If more than 10,000, then that is significant, sir. Urine BKV is not very sensitive, sir. So normally it is not recommended. So blood BKV would be the ideal thing. If we do a biopsy,
recommendation is you look at the viremia. I mean, that's what the
blood
guidelines say. So the easiest thing would be to look for the viremia.
Yes, sir. Yes, sir.
And biopsy is also very useful because you can demonstrate the virus.
Yes, and Hoffman bodies we could
nephropathy, then biopsy. So there is a point, even if you get somebody with slowly rising creatinine, 3, 4, whatever, and if you are considering these 3, 4 diagnoses,
yes, sir.
some people will do a biopsy. Why you don't want to do a biopsy? That is the second question.
Sir, what I thought was creatinine of 3 to 4 when he was in 2020-21. At that time, I would have biopsied. But when he was already reaching 4 to 5, then the benefit of biopsy would not be significant, sir.
Yeah, the basic thing is you are worried the complications of the biopsy
That
because of
three
the bleeding and all.
biopsies, sir.
But the information, if you're making these 3-4 diagnoses of
Yes.
CPMR and the antibody-mediated BKV or recurrence, then
Yes.
biopsy will give you information, and that information, whether it will result in recovery or not, it will be very important for planning the
Yes.
management.
Yes, sir.
How would you like, how would the biopsy, suppose you do a biopsy and whether it is just IFTA or it is chronic active antibody mediated rejection, how would you differentiate the two? Because there could be IFTA still there because he's had 2 rejections, then slowly there is some progression.
Yes, sir. Sir, if we biopsy him at this point of time, one would be, I am expecting in the glomerular compartment, transplant glomerulopathy is expected with thickening and duplication of the glomerular basement membrane. Peritubular capillary multilayering may or may not be there, sir. The tubules and interstitium, however, would have significant damage with loss of brush border, and significant IFTA would have set at this point of time, sir. It would be moderate to severe IFTA, but we would find the evidence of transplant glomerulopathy, sir.
Okay. If you're thinking of chronic active antibody mediated rejection,
Yes,
then
sir.
what would be something very important indicator on a allograft biopsy?
So if chronic active edema, one would be glomerulitis with peritubular basement membrane multilayering, transplant glomerulopathy, and if it is evidence of no, so mostly transplant glomerulopathy and peritubular capillary basement membrane multilayering, sir. Chronic active APMR.
Okay. I think the other thing you should keep in mind is the immunofluorescence showing C4D staining. Because even if it is a chronic active antibody mediated rejection, you will find C4D. If it is pure IFTA, then you won't find C4D staining. So C4D gives you a clue. I'm talking of chronic ABMR, active chronic. Acute
Chronic
also. Yeah.
C4D would be less likely. No? So with if already we are expecting almost 10 years after transplant with severe IFTA, C4D is a bit less
If
likely.
it is, you're right. If it is burnt out,
Yes, sir.
then it is only IFTA.
Yes, sir.
Rejections can finally burn out into IFTA.
Yes, sir.
But if it is still an element is there, that is the way to differentiate. And some people may even, if the advanced chronicity is not that much, then there may be some point in treating those cases also. But C4D is one indicator. And the same way is that if it is recurrence of IgA, then immunofluorescence will show you.
IgA deposits. Yes. The mesangial IgA deposits.
Even if IgA deposits in the so immunofluorescence is also very important in allograft biopsy.
Yes,
You have to, I mean, versus the possibility that you can treat something. The other thing is the diagnosis will help you, how it will help you to counsel for the next transplant. What is the other blood test? You said sensitization.
Yes,
How
sir.
would you test this patient for sensitization?
So first would be to do a CDC cross-match. If CDC cross-match is positive, T cell cross-match.
What is the full form of CDC?
The complement-dependent cytotoxicity.
Okay.
If CDC T cell cross-match is positive, that would more be an absolute contraindication for this donor. B cell positivity we can still consider. We can do CDC enhancement with DTT and AHG, sir. Second, what I would like to do is a flow cross-match, sir, to look if
CDC and means enhancement.
No, not enhancement, sir. CDC with DTT, sir, just to remove IgM antibodies.
Okay. So how does DTT help?
So CDC can be positive due to cell lysis by either IgM or IgG antibodies.
Yeah.
Of more significance is the IgG antibodies, as IgM could be allo antibodies also. So
Yeah.
DTT specifically removes IgG antibodies. So that would just
So it
leave.
denatures the IgM. So if
Yes,
it
sir.
is because of the IgM,
Then it
and
would
you are
become
running
negative.
the test without DTT, with DTT. So with DTT, you will find that it will be negative.
Negative, yes.
Okay.
CDC would be my first test. Second would be because he's a sensitized recipient. He's had a renal transplant earlier, to look at flow cross match, sir. That
Okay.
will improve the sensitivity and specificity of the test. Flow cross match would detect specifically the IgG antibodies, and that would give us some idea of the mean channel shift of the patient. And antibodies are against class 1 or class 2 in nature, sir. And if flow cross match is positive, then I would like to go ahead with a single antigen bead assay, sir, solid phase immunoassay. And
So
that would
will you go for single antigen bead assay only if flow is positive?
sir, in this patient, I would do single antigen bead irrespective, sir, because even if flow is negative and he has specific donor specific antibodies against in the single antigen bead, then we would have to plan desensitization for him. So I would do single antigen bead assay, sir.
Okay. So in such a second transplant, the SAB becomes very important, the information. If it is a first transplant in a patient who has no clinical indicators of sensitization, then it
Yes,
is
sir.
different.
Yes, sir.
But here, all the three may be.
Yes, sir.
Sir, how all the three tests would be, you will be using, suppose all the three you have done,
Yes, sir.
and you
So
will find that in one situation, all the three are positive. You understand? And the second situation, CDC is negative, and flow and SAB are positive. And
yes,
the
sir.
third situation is only SAB showing antibodies, and the flow and CDC are negative. What would it indicate, the individual situations?
So if CDC, flow, and SAB all are positive, then CDC here technically we would be looking at T cell positivity. In those cases, transplant would be contraindicated. So I would not go ahead with this donor at all.
Okay.
One option with CDC positive and planning for a transplant would be it has not imlifidase can be tried, although it has not come into, but it could convert CDC positive to CDC negative cell. So one option would be treating with imlifidase and then planning further desensitization and then considering. However, this would be very high risk with the background of CDC positivity. Sir. If CDC is negative and flow cross match, the second situation is CDC positive, CDC negative, and flow and SAB positive, sir. So in those cases, I would like to look at the mean channel shift values and the MFI values, sir. If the mean channel shift values are less than 300, then the risk of the risk category becomes low to moderate risk, sir. And if the single antigen bead assay MFIs are less than 3000, that also would become low risk sensitization, sir. If on the same, if the mean channel shift values are more than 300, with the SAB values MFIs being more than 3000, or multiple donor specific antibodies, that would be considered a high risk transplant, sir. So I would plan desensitization for him. Third scenario, if CDC is negative, flow is also negative, even then with a history of first renal transplant, I would like to look at SAB. And if SAB, the DSA, the donor specific antibody MFI is quite high, sir, even then it would be high risk, even though flow is negative, sir.
Okay, so all the three tests become crucial. Yes, in this patient. So we don't know. Do you have information whether against the wife, what is the sensitization level?
Yes, sir. His MFIs were quite high, sir. I will just 1 second, sir. His CDC was negative, sir. Flow cross match was the mean channel shift was around 1,335, sir. T cell negative, B cell positive, sir. And donor specific antibodies in the SAB was DQB1 was 29,000, 27,000, and 24,000, sir. So all the MFIs were around above 25,000, sir, against three specific epitopes, sir.
So the anti-DQ DSA positivity, there's no AAB antibodies.
No, sir. DQ positivity is there, sir.
And DQ is 27,000 and the
29,000 and 25,000, sir.
Okay. So, and the flow is also positive.
It's also positive, sir. CDC is negative.
Okay. And what else would you evaluate in the evaluation? What else would you do?
So, in the immunological workup?
Any other evaluation? I mean, immunological, you have done all these three. Anything else you want to do in immunological?
No, sir. CDC and single antigen bead would be enough, sir.
Okay.
Yes, sir.
I mean, I'm talking of basic clinical routine because there's so many experimental tests which you don't do routinely. In the other evaluation, what would you do? In whether the kit, like BKV, have you ruled out totally, or do we have the information about the
We have
BKV?
not done BKV DNA copies. We have not done, sir.
No, it's not done or it's not available.
No, it was not done, sir. BKV was not done.
So should we do it or not?
So even if we do BKV copies right now, so actually I would like to do BKV DNA copies. If the BKV DNA copies are significant, then it helps us preparing better for the second transplant. He's already on minimal immunosuppression, but then I would like to treat him with IVIG in the pre-transplant period, sir. So
yeah, that's why the biopsy, allograft biopsy is also useful, though it may be because if you find BKV,
yes, sir. Yes, sir.
which has, I mean, nephropathy
Yes,
on the allograft biopsy, then you will definitely do a BKV viremia,
yes,
and
sir.
then you have to try to, I mean, you are giving immunosuppression to him.
Yes, sir.
Maybe still patient is on mycophenolate and steroids and tacrolimus, and if suppose the BKV viremia is there, so what would you do?
So if
You have to do something to bring down the viremia, or you are not bothered?
No, sir, I would be bothered. If the BKV copies are more than 10,000, one, I would lower his net immunosuppression, withdraw the anti-proliferative agents. So MMF, I would withdraw first, sir. After that, TAC, he's actually on minimal 0.5 mg BD, sir. So I would continue the TAC and Visolon as of now. I would also like to treat him with IVIG, sir. And I would like to monitor his BKV copies. And I would at least for 6 months, at least monthly for 6 months. And once the BKV copies are negative, then plan for a renal transplant, as he would require extra immunosuppression in the second transplant period, sir. So I would take a time of 6 to 9 months before planning for second transplant, if BKV was positive, sir. Leflunomide at this point with severe renal dysfunction would be a bit tricky, sir. But IVIG, I would like to give him, sir.
IVIG you can give because there's some role, though not proven.
Yes, sir.
The other thing is that if suppose this patient has a donor, which we have.
Yes.
Is there any role of nephrectomy in this patient for any seeing this scenario? Any role? Benefits or negative?
Sir, long-standing.
This is a sensitized patient, and suppose you find the BKV viremia is there, and now he has the IFTA advanced irreversible graft. You have done a biopsy, and there is no reversibility.
Yes.
So do you still do any nephrectomies, graft nephrectomies?
Sir, graft nephrectomy is actually not indicated. the graft after so many years would already have developed tolerance. So the graft would not really be immunogenic at this point of time. With minimal immunosuppression, graft can be managed unless it is uh, causing recurrent graft pyelonephritis or graft intolerance. I would not offer graft nephrectomy to him. And the BKV, if the biopsy comes as BKV also, sir, the BKV blood DNA copies would also already be significant, sir. So I don't think there would be a point in removing the graft. It is going to be a small fibrosed graft most likely at this point of time. So it would not really, we would not gain any benefit from doing a graft nephrectomy, sir.
Yeah, I mean, now less and less of graft nephrectomies are done. The only one of the indications is that if the patient is on immunosuppression,
Yes, sir.
and why you don't want to, and you know that there is no active chronic ABMR or anything, and you want to withdraw
Yes,
the
sir.
immunosuppression, why give it? Because their side effects, complications because of immunosuppression are there. Why you don't want to do it?
So one would be a sclerosed graft would actually require very minimal immunosuppression. And
No, my question is that why we don't withdraw the immunosuppression in a patient who has had 2-3 rejections and reached now chronic allograft failure.
if
We
we
are still
complete,
keeping this patient on minimum immunosuppression.
if we
And sometimes
completely,
even suppose he wants to go for transplant
yes, sir.
and he has had 2-3 rejections and within a year has reached the chronic allograft failure.
Yes, sir.
So why? What is the reason you don't want to stop immunosuppression altogether?
So
You
if
are
we
still
stop the
keeping on with
yes, sir, if the immunosuppression is completely stopped, the patient might develop graft intolerance, no, sir?
graft intolerance means?
The graft is actually an immunogenic structure, which over the years and immunosuppression, it has become non-immunogenic as of now. But if we completely withdraw the immunosuppression, the graft might have some immunogenicity, and acute rejection could still be triggered in a sclerosed graft if we completely stop the immunosuppression, sir.
Yeah, that, I mean, what practically can happen is the graft can swell up,
Yes,
patient
sir.
will start having hematuria.
Yes, sir.
You understand? So you want to keep this thing in check. So you want
Yes.
to give minimum immunosuppression.
Yes, sir. And graft nephrectomy would have surgical complications also. Uh, and if minimal immunosuppression, like 5 milligram of steroids, or if it can be managed, it is not a very significant dose which is predisposing the patient to infections or any other steroid complications, then surgical risk of undergoing a procedure, it's a fibrosed graft over the years. So surgically also the removal would be challenging.
Okay, the last, because since the time allotted to us was we are completed, the last question is that how confident you are with this patient, the type of immunological profile with BANFF as a donor. So how confident you are that this graft after desensitization will sail through without much of a problem? Or what are the problems you are anticipating? You are planning a desensitization you have written
Yes.
with the column, and but the column which you're going to use, this is which column we are using?
Sir, we are using immunoadsorption column. It's a company called Immunocore, sir.
So there it removes the HLA antibodies?
Yes, sir. Yes, sir. Yes, sir. The Immunocore has specific panel for anti-HLA antibodies. So we are planning to use Immunocore at least 6 sessions. But so actually, the ideal plan for him would be to use immunoadsorption for anti-HLA antibodies at least 6 to 12 sessions. Plan rituximab anti-CD20 for at least 1 or 2 doses pre-transplant. I would also like to do some plasmapheresis if cost constraint is there. Like double filtration plasmapheresis would also aid in further removal of anti-HLA antibodies. Repeat a single antigen bead pre-transplant and plan for induction with solimidrol, antithymocyte globulin, and eculizumab if possible, sir.
Okay. So the column which you are talking about, you have used it previously, anti-HLA specific, because most of these columns, the one which you have mentioned is mainly for plasmapheresis, where
Yes,
you
sir.
can plasma can be
Yes,
reused.
yes, sir.
But the other column which you are mentioning, what is the experience? Any published reports and all for the
Actually,
anti-HLA?
there is no published report as of now with immunocore, sir. We have been using this for another patient who was fourth renal transplant. So we have used in him. He's also planned for transplant. So as of now, we are not sure how successful it is going to be, sir.
Okay. And if suppose he goes with the transplant, what would be a post-transplant monitoring for this patient?
So post-transplant monitoring would be
Immunological monitoring and other monitoring because
so immunological monitoring because his MFIs were quite high in the single antigen beat. Even after transplant, I would like to monitor his single antigen beat at least weekly for the first 4 weeks, and then twice in a month for the next 2 months, and then once in 6 months. At any point, if the single antigen beat, there is development of new either increase in the preformed donor specific antibodies or formation of de novo DSAs, then I would like to again plan either immunocore or double filtration plasmapheresis and enhance his immunosuppression. In view non-immunological monitoring, in view of his prolonged immunosuppression, I would like to monitor his BKV copies at least for the first year of transplant, as his risk of infections is going to be quite high after this. If eculizumab is used, then we have already vaccinated him for meningococcal, sir. And then yes, sir, that is it. Another immunological.
So I will ask another question.
Yes,
You are using a donor against which he is sensitized.
yes, sir.
Is there a possibility, or would you prefer, suppose, a paired kidney donation?
So I would
Because
actually
this, what is his PRA, panel reactive antibody?
his PRA would be 100%,
No,
sir.
no.
Yes.
I'm just asking what is the reading? Because you must have done immunological test. Yeah, it may not be 100%. Why it should be 100%?
At least.
No, you are only finding
Huh.
antibodies against DQ.
DQ, yes, sir. Yes, sir.
There's, I don't know, in the single antigen B assay, were there any other antibodies or no?
No, sir. Only against DQ, sir.
So how it can be 100%?
Yes, sir. Sorry. Yes, sir.
How do you calculate PRA? Now I'll ask you a second question.
Sir, PRA is calculated panel reactive antibody against pooled from the samples of pooled eligible donors, the percentage of antibodies that he would develop. Based on that, we calculate the PRA. If the PRAs are high, even if he gets a kidney, the risk of him being positive or sensitized against that particular recipient would be quite high, sir. If the PRAs are high.
No, you're
That
right. The PRA was classically calculated, what you are mentioning, by a pooled, I mean, not pooled, by doing test against, say, 100 cells.
Yes.
From 100 people in the population, but that is no more done. Because now the PRA is calculated by your single antigen read assay, by the Luminex platform. So if you have 100% PRA, or if you have 70% or 80% PRA, it will give you a clue that possibly if it is 70%, you can still get a donor against which the DSA may not be there. You understand? So it will make a difference. So that PRA will be a very important test in this patient.
Yes, sir.
If the PRA is 100%, then possibility of getting a negative donor is not that high.
It's not that.
So the most important thing is even if the PRA is high, if you can get a donor against which there is no DSA, you
Yes.
can go ahead.
Yes, sir. We would do CPRA actually, sir. That is what we do now.
PRA is done by the Luminex platform.
Yes, sir. So if any
It won't be
unacceptable,
100%. If there is no
yes,
antibody against A and B and only
yes,
antibodies against DQ,
yes, sir.
it is not calculated 100%. So in that scenario, would you prefer looking for some paired kidney donation?
Yes, sir. The
Do you
ideal
do?
would be, yes, sir. Yes, sir. The ideal would be to do paired kidney donation. We have actually offered him. First step was to look for another donor in the family. If that was not possible, then look for paired kidney donation.
Yeah.
But the time for waiting for paired kidney donation, they wanted to go ahead with wife as the donor, sir.
Yeah,
So,
no,
but
that's
ideal
fine.
would
But
be to
paired
go
kidney
with paired.
donation with a negative DSA
Yes,
will
sir.
be much more, I mean, outcomes will be better. In
Yes,
this
sir.
patient, the long-term, short-term outcomes both uh,
Yes, sir.
are expected to be, I mean, depending on, you have to give so much of desensitization, then immunosuppression, then monitoring, all those things. So that could be a better option
Yes, sir.
than desensitization.
Yes, sir.
I think we can stop here. Prateek, you have any other question or pointer? Or
If you can ask,
we have crossed the time.
no, sir, good. It's a nice examination. You can ask one or two questions about therapy-related questions or self.
Yeah, therapy, I would say that uh, in terms of the desensitization, she has already mentioned, then what would be your immunosuppression protocol for this patient?
So he would require a triple immunosuppression,
Yeah.
tacrolimus-based immunosuppression, tacrolimus, mycophenolate, and steroids.
Okay. And in terms of the dosing, I mean, do you expect to keep this patient on higher dosing along with the monitoring? That is also important.
Yes.
And
So,
second thing is that what prophylaxis would you use? Because with this immunosuppression, the possibility of infections coming in.
So for him, I would like to keep the immunosuppression dosing would be on the higher end. I would not like, because DSAs were also positive. I would not like to keep immunosuppression on the lower end. So maintain an adequate level of tacrolimus around 8 to 12 in the first 3 months of the transplant period. And with mycophenolate of maybe 1 to 1.5 grams per day, and steroids in the initial period 30 to 35 mg per day. Prophylaxis wise, I would like to give him CMV prophylaxis, sir. So based on his CMV status, if the CMV status is he's deep, if his recipient is negative and donor is positive, then I would like to give for 6 months valganciclovir. If both are positive, then 3 months would be adequate. Another would be pneumococcal prophylaxis, sir. So Septra and trimethoprim sulfamethoxazole I would like to add. Other than that, sir, prophylaxis these two only, sir. Also follow up on vaccinations pre-transplant. If eculizumab is planned, then meningococcal vaccination. Complete his hepatitis B vaccination, as we are also planning to use rituximab. Post-transplant also
So
routinely.
what other vaccinations you use routinely in patients who have pre-transplant or patients on dialysis also?
So pre-transplant or patients on dialysis, ideal would be hepatitis B vaccination. Check their anti-HBs antibody titers. Ideal would be to maintain them above 100. If it is less than 10, then we would give a booster dose, sir.
What about any other vaccines?
The pneumococcal vaccination and influenza vaccination. If the patient is affording enough, then varicella, also Shingrix, I would like to give, sir.
Varicella zoster. Which one? Which vaccine do you use?
Shingrix.
Shingrix. So
Yes,
Shingrix, can you give post-transplant?
Post-transplant, we cannot give, sir. Post-transplant, live vaccines should be avoided post-transplant, sir.
So is this a live vaccine?
So 1 second, sir. So,
Shingrix
should
is
we-
not a live vaccine you can give. Previous vaccine which was marketed,
yes, sir, yes, sir.
that was a
Shingrix.
live vaccine.
Sir.
So that you avoid.
Mm.
So suppose at 1 month you find suddenly the by single antigen bead assay the antibody, donor specific antibody comes up. The MFIs they double up.
Yes, sir.
So what would you do in this patient? Creatine is up, no increase in the serum creatinine. Because you
So
are
if-
doing monitoring every
Yes.
weekly, and after 4 weeks you get this report.
So in his case specifically, what most literature says is chasing the DQ antibody specifically for their titers and trying to achieve a lower titer that would inadequately increase the immunosuppression, as the DQ antibodies do not come down very well with increasing the immunosuppression. If new preformed donor specific antibodies are there with worsening of the graft function, then I would like to increase his immunosuppression, plan further sessions of plasmapheresis. But if graft functions are normal with increase in only DQ antibodies, then I would not increase his immunosuppression, sir.
So you would not do a biopsy.
The biopsy I would do, sir. Biopsy I would do, sir. The immunosuppression wise, sir. If the DSAs are persistently
And the
increasing.
biopsy shows some signs of rejection.
Yes, sir. If the biopsy is showing evidence of rejection, sir, then we would have to definitely treat it based on if it's acute cellular or antibody-mediated rejection, sir.
Okay. And this, like the steroid dosing, if somebody
Yes.
says that you have given such a heavy immunosuppression, so,
Yes.
and all those antibodies and desensitizations, should we, can we stop steroids in this patient, or at 3 months down the line, or use a steroid-free protocol?
So the studies that have been done comparing the steroid-free versus early steroid withdrawal versus standard steroid continuation, they have actually shown that steroid-free group and early steroid withdrawal group both had increased, although the incidence of diabetes and dyslipidemia and steroid complications were less. However, the long term, the rates of rejection were higher in both the groups. So standard steroid continuation group had the most success in terms of rejection, sir. So I would not offer him steroid-free or early steroid withdrawal, sir.
Okay. So the another, I think maybe you have, if the patient asks you, not this type of patient, any patient who's going
Yes.
for transplant,
Yes, sir.
that what is the going to be my survival? A simple question most patients must be asking you. So what
Second
would be your answer? First transplant.
First transplant, sir. Sir, I would explain to him in terms of graft survival and the patient survival. Graft survival in life-related, on an average, graft survival is around, in the first year of transplant is around 92 to 95%. In deceased donor, it is around 89%. Live donor, almost around 95% graft survival is there, sir. Graft loss over 10 years in deceased donor is around 49%, in live donor around 32-35%, sir. And the some mortality, I'm not sure, sir.
What is the half-life?
Sir, half-life, yes,
how do you
half-life.
calculate half-life?
Yes, sir. So half-life would be the half-life is calculated as the amount of years the graft would function with. One second.
Yeah, why this half? There's a half word, half-life.
So the average amount of years the graft is expected to last, sir.
Okay. So the, I mean, living donor transplant, broad group, and the deceased donor transplant, what is the average survival with The
half-life.
patient asks whether I live for 10 years or 20 years or 5 years. That's what they ask.
So half-life for a diseased donor transplant is around 9 years. For a life-related transplant, it is around 12 years. But this is without adjusting for death with a functioning graft, which is the most common cause of graft loss, sir. So if you adjust this for death with a functioning graft, then it is around 14 years for diseased donor and 17 years for live donor, sir.
Okay. You go through all these, definitions. Half-life is how long the 50% of the patient would still be surviving. See, if you say 10 years or 20 years, you are trying to say that at 10 years, 50% of patients would still be alive. These are definitions which are statistically used. So you have to also understand what percentage of grafts are lost because of the death of the patient.
Because of the
Patient's death. Because ultimately,
yes, sir. Yes, sir. Yes, sir.
if the
So
patient is
actually,
dead, even the functioning graft,
yes, sir.
understand? So what is the percentage of such losses? If you
Uh,
do 2,000 transplants,
hmm.
and out of those 2,000, 200 transplants are lost. You have a follow-up of 10, 15 years.
Yes, sir.
So out of these 100 transplants lost,
How
what
many?
percentage will be with functioning grafts?
So actually, death with functioning graft is actually the most common cause of graft loss. That
Yeah.
would be
So
around
on the grossly, what percentage?
uh, so I'm not very sure. 30 to 40% maybe, sir. I'm not very
Yeah,
sure.
but it's almost going up to 50%.
Sure.
There's a big chunk of patients who are
Yes.
lost with functioning graft. Functioning means may not be normal function, maybe still compromised, but
Yes.
they are lost. So it's a very important cause of. So when you calculate, this is what the patient also needs to be counseled.
Yes, sir.
So anyhow, I think Pratik, we can stop now and you can go ahead with the rest of the discussions.
Sir, thank you very much. I was going throughout the class. It was very encouraging and informative, sir, as usual. So my job is slightly to summarize what has been discussed in a very nutshell. Dr. Pallavi, you have presented a case of graft dysfunctions following transplantation with 2 rejections and now preparing for the second transplantation, who is highly sensitized. So sir has asked you about what are the possible diagnoses, and then regarding each points in favor of the diagnosis, like you are telling that is a chronic antibody mediated rejection, cell mediated rejections, BK virus nephropathy, and also he has asked whether recurrence can be a possibility or not.
Yes, sir.
Okay, in the second part of the based on the history, when you are getting the patients in 2023 as ESRD, what are the things that would have been done? It is an ABMR, whether it is an active ABMR or is a burnt out disease. And what about your first diagnosis? Any other diagnosis you have not listed that has been emphasized repeatedly, and the IFTA was the group which we normally all nephrologists we get in the patients with a failed graft. And as because there is a history of ACR in the previous types, and you have to coin the term IFTA because this is so important. Why there is CNI toxicity has asked, he has suggested what suggests you to diagnose the case here as a BK virus nephropathy, and what may be the signs and symptoms? You've rightly answered. And what additional things you should tell, because you missed some of the family history and the examination. It is better to tell the family history with the history itself. And regarding the immunosuppressions and other family members are available for the transplantations or not.
Pratik, there are 2 questions which have come in the chat box. One
Yes,
is that if we have discussed it, if he's being planned for second transplant, then blood BKV, TAC level, and imaging
yes.
and kidney biopsy. So that I mentioned, there is one school of thought that unless you are very sure, the biopsy should be done, because biopsy would very easily give you some indication of BKV and recurrence. If you're not doing a biopsy, you may be more, you have to look for BK viremia even after the biopsy. especially if you find BKV staining positive, TAC level will give you an indication whether there's a high dosing and high exposure. Sometimes the patients are not metabolizing well, even if your low dose may not be very high. If high exposure is there, then there's a possibility of TAC toxicity. Imaging, yeah, I mean, ultrasound was also done. That is always done, and biopsy. The second question they are asking, we have tried to explain PRA. PRA classically, actually, as we talked about the test previously, when the CDC was the test, that is complement dependent cytotoxicity, which was, you might have heard Terasaki. Paul Terasaki was the one who designed that. Have you seen that plastic plate where the CDC is done? So the initial PRA calculation was by using at least 100 cells from the population and doing a CDC. So what they will do is they will take 100 cells, these were voluntary donors, separate their lymphocytes, put it in the Terasaki plates and freeze them away, put it away. And when the serum comes, then you run CDC in those against, and then try to find out, because cells are already there from 100 donors. And out of those 100 donors, what percentage is positive? If 50 are showing CDC positivity, then it will be called 50% PRA. That was the initial. But now it is all changed with the Luminex platform, where the calculated PRA is there, which is more representative, presuming that the software has the profile of the population in terms of their HLA phenotype. See, like one criticism which is done against the Luminex platform for calculating PRA for Indian patient is that the kits are made in USA. So they are using software where the information is from the North American population. So that's why what the kit manufacturers they do, they also try to incorporate from other geographical regions, so that when Indian patients we are looking at this CPRA, then it is more. But CPRA is much better even with this type of flaw than the classical CDC PRA. So as we have discussed, I'm again re-emphasizing PRA, if it is not 100%, we should be more aggressive to get a paired kidney donor against which the DSA is not positive. So I think these were the only two questions in the chat.
I had one doubt, sir.
Yeah.
So let's say we biopsy him at this point, and there is some evidence, there is IFTA is there, and evidence of BKV nephropathy. We check the BKV viral load, and that is significant, sir. How long would we decide to wait for the transplants? Or would we wait for BKV DNA to become negative and then plan for a transplant? Because he would again be, subjected to a lot of immunosuppression. So this BKV could actually go up again, sir, even if the levels are negative.
No, you are right. Because what you have to see that with so much of heavy immunosuppression, he will have a lot of BK viremia coming up.
Yes,
if
sir.
you don't start with a BKV negative status in terms of viremia,
Yes, sir.
and you must understand that the BK viremia may be negative, but still you may find virus in the
BKV nephropathy. Yes,
in
sir.
the tissues and all,
Yes, sir.
which may flare up with
Yes,
the heavy desensitization protocols. In the normal situation where the patient is not sensitized and you are not going to do very heavy immunosuppression, still it is expected that you will try to reach a stage of BK viremia disappearing and then go for the transplant. Your question is, if it doesn't happen in this case, my take would be that you should not go with the desensitization protocol. Better aggressively look for a paired kidney donor against which there is no DSA. and then try to, I mean, you can use IVIG and other things and then see if it helps. Sometimes IVIG may not even help because
Yes.
those are all not very much tested and confirmed anti-BKV interventions.
Yes, sir.
So just just because important source is that Pallavi, this is a BK virus is mostly comes from the donor. Basically is a donor derived one. So there's a concept also that you should test a viruria at least for the donor before taking the graft.
Yes, sir.
And
Just
some people even do a nephrectomy, though it has not been shown because the nephrectomy is from the donor and maybe that is the source which was initially there, which we missed.
and regarding this CPRA, suppose I'm just giving some example which you have told. Suppose a patient having an antibody against HLA-B52, and you know this B52 is present around 40% of the population. Then your CPRA is 40%. Suppose the patient is having an additionally B17 antibody, and this is present another 30% of the cases. So it may be a combined. So 25, so 40 plus 30, 70% will be the CPRA if there is no double sharing like that. Yes. Sir, just I am just in few minutes I am just concluding this summary. Sir, another asked you whether the patient would have come at the creatinine of 4 and 5. What additional thing you would have been done, which is not done in these patients, and he was repeatedly asking about the importance of the biopsy. It is important not because of this is a chronically graft is lost, but also if it is a BK virus nephropathy, if it is a recurrent disease, and if the activity of the antibody mediated rejections. And then so biopsy is always logical in this group of the patients. Then he has asked another question, how to differentiate between the IFTA and chronic antibody mediated rejection, because in both the situation you get some amount of the interstitial nephritis and tubular atrophy. And importance of C4D staining, even though it is an advanced stage, it is very important to differentiate. It is a basically T cell related origin or antibody is still mediating. And then you told that this is sensitized patient. He asked about what are the tests of the sensitization, CDC full form, how DTT helps. You have answered very nicely. And there is also there's IgA recurrence that is done by the immunofluorescence. Sometimes we give the biopsy by prescribing simply this is a biopsy and C4D. That may not be enough when you're considering this is a recurrence of the disease. How we'll go about the SAB testing, and 3 situation he has given you: CDC, flow cross match, and this DSA is positive. Sometimes DSA and flow cross match both 3 as positive. When the CDC and flow positive, DSA negative, and only this is a one thing is positive in 3 situations. So we get in the practical these situations, these things, and how to go about, and there is a discussion about that. And what MFI you did get, and what are the important MFIs and how it is tested, and what else investigation, basic investigation he has asked other than this sophisticated immunological investigations. In this allograft biopsy was discussed. And about the triple immunosuppression, why should you continue triple immunosuppression even in a failed graft, and which immunosuppression should you continue, and what is the role of nephrectomy in a patient who is highly sensitized and lost his graft, and why don't you completely withdraw the immunosuppression in such of patients. He has asked you how comfortable you are for doing a second transplantation in such a sensitized patients, and what will be your strategy, and how do you perform this immunoadsorption, because many of us do not perform this immunoadsorption, we do the plasmapheresis. He has asked you about this is how will be the monitoring in the post transplantation period, in the immediate period, in the later period. If you he has asked about the PRA and CPRA, we have already discussed. And finally about this is if you get a CPRA in these patients and look for possibility of a paired kidney exchange program. Immune suppression protocol, what about the monitoring in the post transplantations, what will be your prophylaxis, what vaccination you prescribe for the pre-transplant and the dialysis patients, particularly the varicella vaccines and other varicella vaccines, and also for the live vaccines. If the DSA SAB is positive, MFI is very high, and creatinine is not going high in a post-transplant period, will you still do a biopsy or not? And if it is the biopsy showing the rejection, whether we will treat it or not, whether steroid dosing withdrawal or minimization, this is beneficial for a sensitized patient undergoing second transplantations. Any patient, if they ask you, is a vital question, is asked by every patient ask us about what will be my survival, that you should answer confidently. What is the half-life, how the half-life of a graft or a kidney transplantation is calculated, and percentage of the graft loss due to the patients with the functioning graft, and the percentages. So these are the discussions was done, and according to sir, our protocol is you should rate the examinee and tell whether he is ready for the passing examination or not, according to your opinion.
And if she is ready, she is good. I mean, there's always, because this was a difficult clinical problem, though the case is very straightforward. But the basic thing is that the candidate should start with the chronic allograft failure and the possible differential diagnosis. And always keep in mind one of the first possibility of IFTA, chronic allograft dysfunction. But the other three would come in as a differential diagnosis. It's very important. So I would rate that she is very good, and I think she should pass the examination. The one question I'm just, because I was just seeing the chat box, maybe
Yes.
Pallavi can try to answer. What is the role of everolimus if BK nephropathy, virus nephropathy is detected in biopsy? In terms of like you biopsy this patient and you find BK virus and she is going for a second transplant. So would you use everolimus as a immunosuppressive drug?
Sir, I would not. I would still, because it is second transplant, I would still stick to tacrolimus based immunosuppression. If at max we can consider 4-drug therapy with for decreasing the dose of tacrolimus specifically, we could add everolimus. But only everolimus based immunosuppression, I don't think I would do, sir. That would increase the chances of rejection significantly, sir.
Yeah, you are right. Everolimus based like Ascent trial and other trials have also come.
Yes,
They
sir.
are in combination with the tacrolimus CNIs, and the CNI dose is reduced, but such patients are excluded from those studies. The
Yes,
high
sir.
risk patients who are sensitized. So for a second transplant, everolimus is not a good drug to use.
So most
Everolimus has been shown, I think why this question might have uh, come up is that everolimus has been shown in vitro to have some anti-BKV. So if you have a mundane case of BK virus nephropathy, then some people have converted
yes, sir.
the immunosuppression to everolimus based. But for a second transplant, in this case, everolimus based immunosuppression would be inferior in terms of the control or prevention of rejection.
Yes, sir.
So thank you very much.
The trials that they have done, the convert and transform trial, they actually did not include the high risk recipients in
Yeah,
which everolimus and sirolimus were shown non-inferior, but they did not have high risk recipients, sir.
sure.
Yes, sir.
My one suggestion to Pallavi, just while telling the history, examination, everything, you just bit a slow, is slightly, because me and Miss are like examiners will like that. It may not follow all the things you have. You are very nicely answered, but it's slightly slow and get the question actually what the examiner is wanting to know from you, and the answer is that will give you more marks, I think.
Yes,
Yeah, otherwise the examiner has to strain what
That's
the candidate is talking about. So it's always a good point to be slow and so that the other person understands, and also try to be loud. At times the
yes,
distance between you and the examiner may be there,
yes,
so that everything is audible, and then
yes.
slow, that helps. Yeah.
Thank you, sir.
Thank you, sir. So in the we are, due to lack of time, we are now actually not going to the OSCEs. We are directly going to the BANFF journey by Dr. Aniruddha. So you please go ahead. We are not doing OSCE. If find time, we can add on the next session.
Sure, sir.
Good evening, sir. Shall I start sharing the screen?
Yes, you can start, sir.
Is my screen visible? So, good
Yes.
evening, respected teachers, my seniors, and my colleagues. I'm Dr. Anirudh, and I'll be talking in brief about the evolution of the classification, BANFF classification. So, the journey of BANFF started in 1991 when Dr. Kim Soles and Lorraine Rakusen gathered 12 pathologists in the city of BANFF, and they united with the idea to promote uniformity and approach of the diagnosis in transplant rejections. And it was done for the diagnosis and better diagnosis and for actually generating endpoints for clinical trials. So over this period since 1991, the BANFF classification has been undergoing serial changes through self-organizing group meetings, which happens every 2 years, and the updates are driven forward through consensus of the opinion. So here we look at the fact that starting from 1991, the last and the most current session took place in the month of September of 2024, and most of them came with publications and with certain modifications. So, kind of something like the evolution of an iPhone. I would say something which changes very rapidly. So, whether this is significant or whether the entire thing or the prospect has been evoluting towards something much more conforming. So when we look at the first classification given by BANFF, the original six criteria, there were originally six criteria, which were the normal, the hyperacute rejection, the borderline changes, acute rejection, the chronic allograft nephropathy, and the group of others. And the individual scores were individualized scoring was done in terms of the findings of glomerulitis, interstitial inflammation, tubulitis, and intimal arteritis. And the chronic changes were graded in terms of chronic glomerulopathy, interstitial fibrosis, tubular atrophy, arteriolar hyalurosis, and intimal fibrosis. Now, coming to these individual criteria, over the time period, the category 1 and 6, that is the normal and the others, have remained fairly stable, whereas we see the category 2 as well as category 4, which has undergone multiple changes. So coming to the second category where the most important changes have occurred. So previously, which was known as hyperacute rejection by the second classification in 1997, it was identified as antibody-mediated rejection, and it was classified into type 1 and type 2 depending on the time period. Now coming to the important timelines or in the 2001 classification, the definition and the criteria for acute ABMR came in, which was highlighted in the terms of the morphological evidence of tissue injuries, as well as the evidence of antibody-mediated action on the PTC walls, and as well as in the evidence of anti-HLA or anti-endothelial DSS. And also the term of suspicious ABMR was coined in. In 2005, the criteria for the diagnosis of chronic ABMR came in, where we highlighted the chronic changes of transplant glomerulopathy and the PTCML as well as tubular atrophy with or without PTC loss. The other criteria were kept in continuity. So in 2007, a newer term where the C4D deposition was found without any morphological evidence of rejection was coined in. And also in 2007, the criteria for PTC scoring was finalized, and there was consensus regarding the scoring of how much should be the rate or how much should be the cutoff for the C4D positivity. In 2009, the terms coined in was ENDAS, that is the endothelial activation and injury with expression of endothelial transcripts, and it was taken as a manifestation of ABMR, as it could predict the graft loss with higher sensitivity than C4D. And also from this time, thanks to these genetic transcripts, the identification of C4D negative ABMR started. Coming down further the line, in 2011, it was identified that the C4D had definitive limitations, and due to this, these limitations, the working groups actually started working on C4D negativity and also defining the definitions of acute versus chronic active ABMR and also the significance of intimal arteritis. In 2013, which was a very significant year, the criteria for the diagnosis of C4D negative ABMR was set in, and also in this year, whenever the C4D negative, the C4D was negative, the microvascular inflammation where G plus PTC more than 2 and also the increased expression of NDATs were taken as the alternative criteria. In this modification, also the minimal criteria for glomerularitis and chronic glomerulopathy was updated, and via electron microscopy, the chronic glomerulopathy staging of CG1A was included in this year, and also the focal PTC staining, which was previously not taken in, it was included in the study. And in this year, the scoring for vasculitis or the vascular involvement was brought down to any level of or any intimal involvement was also taken into the criteria of antibody mediated rejection. Now coming to 2015, here the primarily modifications were regarding the PTC staining, and the subsequent more important modifications came in the year of 2017 when the need for an alternative test to DSA was highlighted, as because the DSAs were not always readily available and there were limitations in the current testing methods in which all the DSAs could not be identified. So C4D staining or the C4D positivity was taken as an alternative to DSA positivity. From the acute and active ABMR, the word acute was taken out and it was only coined as active ABMR. And in this year, 2017, the criteria of suspicious for active ABMR or suspicious for chronic active ABMR, they were eliminated. And also in this modifications, the exclusion of isolated PTCs in the presence of TCMR was also introduced, so that it highlighted that in TCMR as well as ABMR, certain findings were common in both the group. And also the gene expression, the portfolio of gene expression was increased, not only to include the NDATs, but also all the validated ABMR genes, because since 2013, the work on gene transcript expression during rejection was started, and by 2017, all these validated ABMR associated genes were taken into account. And also the C4D staining and increased gene expression was also accepted as a substitute for DSA in the serological criteria for DSA negative cases. So if we look at the modifications since 2001, 2013 and 2017, we see that certain group of patients who were previously labeled as suspicious for ABMR in 2001, when we come to the classification criteria of 2013, few got classified as few got classified or diagnosed as definitive antibody mediated rejections, and few could not, and few were maintained in the suspicious ABMR category. Because of this involvement or including the C4D negative criteria in 2013, what happened that the incidence of ABMR and suspicious ABMR increased exponentially. And because of the confusion regarding management of this suspicious group of ABMRs, so in 2017, this criteria was taken out, which again resulted in reduction in the number of proven or documented ABMRs, but there remained a group of patients in which the decision was hankering or pending. Those groups of patients who had significant microvascular inflammation but were negative for DSAs as well as C4D, and also the group in which the patient had DSA but the microvascular inflammation was not up to the mark or the cutoff. So keeping this modifications or these questions in mind, the subsequent BANFF modifications came in. In 2019, there was not much of modification in terms of this microvascular inflammation, whereas in 2019, only the diagnosis of chronic inactive ABMR was rendered when the biopsy had morphological changes, but the C4D was negative, and there was remote DSA positivity in the biopsy. So coming to the modifications in 2022, the most important modification was the involvement of microvascular inflammation and microvascular injury in the antibody-mediated rejection classification in this entire criteria. And in this, the language of the entire classification criterion, which we see has expanded over the time from the first classification, was simplified. In the active lesion, the acute tubular injury was omitted. The language for C4D positivity as well as the microvascular inflammations were simplified, and also the NDATs were again removed. Additionally, for the chronic active antibody-mediated rejection, the criteria required that arterial intimal fibrosis of new onset was removed, and also the criteria was again further simplified to keep in the terms of active antibody-mediated rejection, and the term chronic inactive antibody-mediated rejection was removed. 3 new terms were included in this criteria, which was microvascular inflammation or injury, which was DSA negative and C4D negative, probable antibody-mediated rejection, and C4D staining with acute tubular injury. So coming to the modification which we could see in between the BANFF 2019 and 2022, the 2 groups which we highlighted in the previous picture, the patients with having microvascular inflammation above the threshold, but C4D negative and DSA negative were put in a separate class. That was microvascular inflammation and DSA negative and C4D negative, and the patients who had DSAs but C4D was negative and the microvascular inflammation levels were below the MVI threshold, they were actually classified in the group of probable AMR, or the probable antibody-mediated rejection, thus highlighting the importance that those groups needed further modification, further observation, and maybe alteration in the therapy for prevention or the protection of the graft function. So when we look at the 2022 proposal, we see the classification in which the shortened or the reduced group of ABMR actually now encompasses a larger group of patients in terms of microvascular inflammation. In the group of microvascular inflammation, there are certain groups which are C4D positive, but there are certain groups again which are C4D negative, and they may have other unclear causes of microvascular inflammation like non-HLA antibodies, missing self-allo antibodies, or the ischemic reperfusion injuries. So coming to the continuum of the ABMR, in 2022 group, it was again discussed these further the ABMR which occur much more late in onset, that like the chronic active ABMR or the active smoldering ABMR. The discussion was to actually put in certain activity index or chronicity index, which may in like of that of lupus nephritis, which may again help us in stratifying or prognosticating the course of the graft's life. So coming down to borderline changes, in 2005, it was again suggested and it was confirmed by 2007 that the minimal threshold was brought down. But again, subsequently in 2019, the original threshold of I1T1 based on the studies, 2 groups of studies which actually highlighted that untreated isolated tubulitis was not associated with a significant risk of progressive graft injury. So the threshold was increased. And subsequently, these borderline lesions have been shown to be associated with increased risk of subsequent TCMRs, but again, not always, because certain times they might be only a sequelae of wound healing process and may be related to non-immune mediated injury. Now coming to the acute rejection. Acute rejection was initially classified, and it was the major thrust of the initial BANFF classifications because they mainly focused on these, and they actually phenotypically correlate with the T-cell mediated rejections. So in 1993, in the first classification, tubulitis, endarteritis were recognized as the important features of rejection. inflammation, although was important, but it was not specific for it. It was actually graded into grade 1, 2, and 3, depending on the involvement. Pardon? Subsequently, in 1997, the most important modification was actually there was the cooperative clinical trials in renal transplant, the NIH mediated classification. Both these schemes and the BANFF schemes were fused, and this consensus of having type 1A, 1B, as well as 2A, 2B, and type 3, depending on the vascular involvement, was put in, which has been subsequently followed always. So in 2001, this term of acute or active cellular rejection was coined in to actually differentiate it from the antibody mediated rejection. And also at this point of time, it was identified that isolated endarteritis could be the only manifestation of a severe rejection. By 2005, the present term of T-cell mediated rejection was coined in, and this time the isolated transplant arteriopathy, which was present without other changes of chronic ABMR, was mentioned and highlighted as a chronic TCMR. And subsequently, till the next classification or identification of chronic active TCMR, this chronic TCMR was identified mainly through the presence of transplant arteriopathy. In 2007, inflammation, because multiple studies had shown that previously, because the inflammation was only calculated in the non-scarred cortex or the non-scarred area of the graft, the multiple studies highlighted that inflammation even in the areas of atrophy actually impacted the graft outcome, and that is why the total infiltrate score was coined in which the inflammation in the scarred as well as the non-scarred cortex were taken into account. That was done in 2007. In 2015, because of these studies which followed through, one of the significant studies was the DCAP study, in which it was found that the extent of IIFTA was an independent predictor of the graft loss, and that is why IIFTA was included into the 2015 BANFF classification. And the criteria for grading IIFTA was done, a semi-quantitative criteria was adopted, but it was still not used to diagnose T-cell mediated rejection. And in this year BANFF's classification, the discussion came out that chronic TCMR not only was involved in the arteriopathy, but actually it was also involved in the chronic tubulointerstitial compartment. So based on this finding of chronic TCMR involving the tubulointerstitial compartment, in 2017, the grading for chronic active TCMR was given, in which it was highlighted, or it was classified according to the basis of IIFTA and the inflammation in the scarred and the atrophic cortex. So the suggestion that IIFTA was a sequelae of acute TCMR, as well as it had negative impact on the graft survival, it was observed. And it was also identified that IIFTA was not specific for T-cell mediated rejection, can also occur because of ABMR as well as polyomavirus nephropathy and certain non-immunological lesions like obstruction and infections also. So these were they needed to be ruled out before actually we diagnose it with the diagnosis of chronic active TCMR. In the subsequent years of 2019 and 2022, there has not been major modification in terms of these criteria. However, this chronic active TCMR remains a point of discussion. And in 2019, the term of total IFTA, that is tubulitis in the IFTA, was fully introduced. And also in this 2019 modification, the definition actually enabled to actually define a combined chronic active TCMR as well as an acute borderline TCMR in a graft. So this was the definition. That was the tubulitis was scored in all the cortex, which all the tubules, even if they were mildly or moderately atrophic, only severely atrophic tubules were avoided. And for preserved cortex, it was tubulitis score, and for areas of interstitial fibrosis, this was T-IFTA. So coming to the next category, that was chronic allograft nephropathy. In 1991, it was highlighted as a non-specific etiology. By 1997, it was graded according to the severity, but they were mainly non-specific. So in 2005, the term chronic allograft nephropathy was removed, as because it was a non-specific term, and it was replaced with the term service describing, that is IFTA, which was graded according to its severity, and it was continued throughout till 2019 when the category 5 was replaced with polyomavirus nephropathy, in which PVN grading was done based on the PVL as well as the chronic inflammation score. Subsequently, in 2022, we see the PVL has been moved to category 6 or the others, and the IFTA classification has been re-put. So the sixth category, which has remained unchanged, that is the other non-rejection related diagnosis in renal allograft transplant, like the de novo glomerulitis as well as drug-related injuries like tacrolimus or CNI nephrotoxicity, and the polyomavirus nephropathy has been continued in this particular group. So this image again highlights the more important modifications which came in through all these years. Coming towards the forward and looking towards the future, the BANFF group has been working on couple of aspects which are not yet put in the classification categories. One of the most important aspect is the generation of the molecular microscope as well as the gene transcripts which enable us to identify PCMR as well as ABMRs in a much more accurate way. They are still to be incorporated in a particular category. And apart from that, there has been more work on the incorporation of artificial intelligence and in this BANFF classification groups. One of the pathways which is paving in is the formation of BANFF Digital Pathology Working Group, in which image bank or a digital bank is being constructed. And subsequently, the next thing which is again coming in for discussion during 2022, as this image shows, Dr. Robert Montgomery with the first patient of having a xenotransplanted kidney from a pig. So because of this newer highlights, the BANFF modified itself, and the requirement for having BANFF classification for xenotransplant kidneys and xenotransplant rejection is the need of the hour. And for that, in 2022, the discussion was put in for having the classifications for the xenotransplants as well as the molecular diagnosis, that was the BPOT, which resembles the BHOT for human gene expression panels. The BPOT for the first cross-species gene expression panel for identification of rejection was done, and the proposed BANFF scoring for xenograft was highlighted. These are not yet to be, they are yet to be accepted, and they were probably discussed during the meeting in September 2024, which was concluded, which is the reports of which are pending. With this, I would like to conclude. Thank you.
Thank you, Dr. Aniruddha, for this nice deliberation. The idea of keeping this discussion here, because we wanted to show you how a science can be built up from nothing. There is nothing called a transplant pathology, and that is from the zero. In a journey of so many years, they have built a complete science of recognizing and diagnosing the transplant pathology. It is a diagnostic one, not a prognostic one. Nothing, no prognosis can be ascertained from this, and this is a separate chapter. Secondly, when you read this classification, sometimes you get bored. I have seen so many people are leaving. So if you want to remember, you have to think it logically. In each cases, what the changes has been done and how it is done, why it is done, these are very important, and it helps you to remember properly this BANFF classification. This is an essential part of treating any patients who is suffering from a dysfunction following renal transplantation. And thank you. So we are at the end of the session, and thanks to.
Can I make just one comment? Just
yes, sir.
The interesting thing about BANFF classification is that the name BANFF started because these people met in Banff, which is because I was in Canada, Alberta, Edmonton. So Banff is a hill station. So they just met there. It was like combining the academics and also like a holiday. From there, the activity started, and I think Anirudh has shown the journey, how it has evolved very scientifically, because they were trying to create evidence. And it has resulted in publications, which you all know, and some classifications, which are very much followed. Only one more last comment. Kim Solis realized that the journey has now gone to a limit, so it has to expand the horizon. So he has the BANFF they have made a foundation now, which is actually running the whole endeavor. So the first thing they have done is they have opened up. Now, though it is called BANFF meetings, but it is not held in BANFF. Like this 24 meeting is actually held in Paris. So it has become like an international meeting, which will rotate in different places. That is one opening up. The second opening up they have realized is that just limiting to the histopathology or molecule is not enough. So the molecular microscope is one thing on which they have worked, but they are going in very different direction, like a cyber pathology, using internet, using xenotransplantation, regeneration. They were not the initial goals of the BANFF when it started. So they have really opened up into new horizons. So it remains relevant also in the direction in which medicine is going.
Thank you, sir, for being with us. We are very much honored that you are here. We have learned so many things. So we have to end the session now. And thanks to the whole micro lab team, specifically Mr. Shourav, who has done so many things for this, starting from making the flyers and also Mr. Amol for all this technical support. And thank you very much. And Ashish is there. And thanks who have all have joined. Now hand over to Mr. Shourav for ending the session.
Thank you very much, Dr. Das, and our heartfelt gratitude on behalf of the entire student fraternity to Professor Sharma for for spending your invaluable time and to prepare all the students. I think that in the month of February the students are actually going to appear for their exams. That's what I came to know from one of the faculty in Chennai. So I'm wishing all the best to all the aspirants. And I just would like to tell Dr. Das, sir, your immense guidance has helped to shape up this particular curriculum, and the students are actually taking immense benefit out of it. Whenever I'm going to different locations, the students are expressing their gratitude to all of you. My thanks to Dr. Aniruddha, my best wishes to Dr. Pallavi. I think that the moment the examiner says that yes, she has been passed out, we also are having a sigh of relief. Yes, thank you very much. And our next class would be commenced when, sir? It is on 4th of January?
Yes, 4th of January.
4th of January. So till then, wishing you Merry Christmas and wishing you a happy and prosperous New Year ahead. Thank you very much on behalf of Microlabs. Wishing you a very good night ahead. Thank you very much, sir. Thank you.
Thank you.
Thank you.
Thanks, sir.
Thank you.